Okay, good morning everyone. Welcome to today's webinar with Arkansas Department of Human Services. This webinar is brought to you by AFMC and we'll be providing a behavioral health transition update this morning. But before we get started, I would like to go over just a few logistics. To eliminate background noise, the phone lines are being muted during today's event. Questions may be submitted through the online Q&A section located to the right of your screen, and we're going to answer those probably throughout and then again at the end of the session. And today's event will be recorded and posted to the AFMC website. Once posted, all attendees will receive an email including a link to today's recording. I'm now going to turn the presentation over to Trish Gann, Assistant Director of Behavioral Health Services. Trish?
Good morning. We usually say good afternoon, but we moved our time today. So good morning, and thank you all for attending the webinar today. I just want to tell you that we will have representatives from our PASAs, or the plan is to have representatives from each of the PASAs here today, and they will be giving you an update on what's going on. But we're going to kind of go through some slides, take a few questions, then have some updates for them, and try to answer as many of your questions as we can. And there's just a lot going on. So let's talk first. Just want to kind of recap independent assessments and make sure everyone understands about independent assessments. So referrals for independent assessments should be based on clinical evaluation of the beneficiary and the identification through treatment records or ongoing treatment of chronic long-term functional deficits due to a behavioral health disorder. It's recommended that beneficiaries with acute needs be treated and evaluated through the Outpatient Behavioral Health Services program to determine the existence of a chronic functional deficit versus if this is just an acute need, which may be addressed through professional clinical services. As of March 1st, the supplemental information forms are no longer going to be reviewed by Optum as part of the assessment process. These forms were used in phase 1 of the transformation process in order to gather pertinent information based on treatment history from providers to identify potential areas of questioning during the assessment. Beneficiary guardians, including DCFS family service workers, I can't talk today, 9/11 monitors, parents, legal guardians, or other persons who can be there with the beneficiary may participate in person. The provider cannot participate in that independent assessment. It should be independent. But other persons may participate in person or via phone to provide information on beneficiaries' functional statuses. So the independent assessment referral process. For referrals for an independent assessment, those are now being processed through EQ Health. We forgot to close the gap on one of those slides. Referrals submitted to EQ Health prior to 2 p.m. on Monday through Friday, excluding holidays, are then sent to Optum on the day that they're submitted to EQ Health. Referrals submitted to EQ Health after 2 p.m. Monday through Friday, excluding holidays, will be sent to Optum the next business day following submission. Providers should allow up to 48 hours after a file is sent to Optum for loading. So you know that that file is going to be sent over if you get your referral in before 2, probably a little earlier than 2, but if you get it in, then the file is going to go over to Optum the next day or that day. So just give it a little bit of time to make sure that that referral is uploaded into the ARIA system and that that referral is available. And then beneficiaries can begin directly calling Optum to schedule an independent assessment. They don't have to wait until Optum contacts them. They don't have to wait until they receive their letter. They can go ahead and start calling, but you probably want to be giving them some time to get that referral over there so you can schedule it. Once the file is uploaded to Optum, a letter is automatically generated and mailed to the beneficiary with the address that you put in the referral, or guardian, notifying them of the referral and that Optum is going to be contacting them to schedule that assessment. The phone number to schedule that assessment is also included in the letter, and beneficiaries don't have to wait for Optum to call them. They can call and schedule that assessment immediately upon receipt of that letter. The file creating the independent assessment referral in the Optum system is automatically loaded into an auto dialer within 24 hours of receipt of that assessment, and then the phone calls are going to begin on those referrals that have a pending status. The phone calls are made Monday through Friday, with calls made at different times on different days. After the auto dialer has attempted 3 calls, then there's going to be a phone call to the referring agency or site requesting updated information. So the information should be good. This is a very short time frame, unlike when we had our embed, where we had information coming in that might sit out there for a while before that person is called. And this process should be relatively quick, and therefore the information should be good. But they're still going to give you a call to see if there's any updated information, and at that point in time, they're going to either call with that updated information, or if there's no updated information, then they're going to move to a calls complete status. At the end of the required period for outpatient referrals, that's 14 days. For inpatient acute referrals, it's 7. They have a 7-day turnaround. The referral is moved to a pending closure status. While in the pending closure status, beneficiaries can call to schedule a referral, and this will be up to 20 days after that pending closure status was initiated. So you get to the 14 days, and they're going to move that over to pending closure, and then that referral will remain open for another 20 days for that beneficiary to call and schedule that independent assessment. Pending are referrals that are pending a scheduled appointment. Calls complete, Optum has completed the required outreach calls. Pending closure is when that's moved over, and there's a 20-day grace period prior to the closure of that referral, and then there's closed. There's also a scheduled status, which that means that there has been an independent assessment scheduled, and beneficiaries certainly have the ability to decline to have an independent assessment completed, and if they decline an independent assessment, then that referral will be closed. So again, scheduled, declined, there was no response, there was an assessment scheduled, or the beneficiary guardian didn't show for that assessment, so we do have those. Assessment canceled, assessment rescheduled. So those are some other things that might happen with that independent assessment. The independent assessment referral process, the following local numbers will appear on the caller ID. So when these beneficiaries are getting phone calls, this is the number that's going to appear on the ID. The caller ID information is going to be DHS assessment, and the scheduling contact number is going to be 844-809-9538. If the beneficiary does not answer and there isn't a voicemail box, then a message is left indicating the purpose of the call and the contact number for the beneficiary to call to schedule the assessment. The results of the reassessment, so we want to talk about reassessment. We were talking about assessments and we skipped over, now we're talking about reassessment. So for the periodic reassessments, the results of those periodic reassessments are going to be automated over to the PASAs. The PASAs and Optum are working together on a coordinated effort for these reassessments, and will continue to work on the details of how this will happen in the reporting. And just please remember that the appeals process and timelines will be applied for beneficiaries who complete a reassessment if there is a tier drop to a Tier 1 that will cause disenrollment from the PAS, or where there will be a loss of eligibility for Tier 2 or Tier 3 services for those eligible outside of the PAS. I don't see any questions about that, except the Hispanic version, and no, we do not have a Hispanic version of that letter. The reason we don't have a Hispanic version of that letter, we can certainly get one if we need to, but we have no idea. There is no way for Optum to capture whether or not a beneficiary is Spanish speaking. So we have no way to capture that information for a special letter to be sent out to that beneficiary. So there's a couple of questions we'll just answer real quickly. So when we now see all remarks on our weekly status report from Optum, the status report's not changing at this time. We're looking at that status report. Let's see, we've already answered that one. We've got a question in here about the passes and about requesting EOBs or PAs, and we'll have our passes give you an update in a little bit, so we'll answer some of those questions. So there's a question, how will a provider know about the reassessments? Certainly you could talk with your beneficiary. They will get a results packet and they will know that they've been reassessed. Statuses will be updated in interchange or in Medicaid. So when you're looking on the Medicaid eligibility strip, and we're going to talk about that later, you will certainly know if there's been a change. But those statuses for reassessments will be updated and sent to the passes. Can a residential provider refer a client that is a Tier 2 and has been since their assessment date for an assessment due to the severity of symptoms? No. Once a beneficiary goes into a PAS, that beneficiary is in the PAS and there is no option for a reassessment. The only options for reassessment are for beneficiaries who receive a Tier 1 determination, and those, there's a slide in here where we'll talk about that. But beneficiaries who are in a PAS, their services are driven by their person-centered service plan. Their eligibility for PAS is driven by their tier. Are reassessments being scheduled by the care coordinators? I think that care coordinators, we can have our passes talk about that, but I believe that care coordinators are assisting beneficiaries in scheduling their reassessment. They're nodding. How often are reassessments going to occur? That depends on the type of assessment that they received. The only way to get a reassessment is for a Tier 1 beneficiary, and those still, we'll talk about that in a minute. So let's talk a little bit about PAS. So all beneficiaries assessed prior to March 1st of 2019 as a Tier 2 or Tier 3 who qualify for PAS assignment should now be enrolled in a PAS. I think today's the 7th. So they should be enrolled in a PAS at this point in time, I believe. PAS enrollment should be reflected on the Medicaid eligibility screen. It's under the Managed Care tab, so you should be able to look for your beneficiary's PAS assignment. Just want to make sure that everyone's aware that PAS assignments, to look for PAS end dates. Beneficiaries may change PASs during the open enrollment period, and the PAS assignment may change, or members may lose eligibility due to loss of Medicaid coverage or change in Medicaid eligibility category. Beneficiaries who receive an independent assessment after March 1st of 2019 will automatically be assigned to a PAS when an assessment result file is received from Optum. That goes through another vendor with the state, and they're automatically auto-assigned to a PAS. The PAS will be notified of the assignment, and a letter will be mailed to the member notifying them of their PAS assignment. 7 days after the auto-assignment, the beneficiary becomes a member of the PAS, and the PAS assignment will be available on the Medicaid eligibility strip. Please remember that this process is based on their Medicaid eligibility category. There are beneficiaries who will get independent assessments who will not be eligible to go into a PAS, and we have some Medicaid eligibility categories that we are attempting to screen out, but those Medicaid eligibility categories are not, may not go into a PAS or receive Tier 2 or Tier 3 services. If there is no PAS assignment, then the recommendation is to check eligibility. to determine whether or not the beneficiary continues to be eligible or have active Medicaid, to check their eligibility category. They may not have a PASS assignment due to being in medically frail, having spin down category, being on AR choices waiver, which is based on aid categories. They may have independent choices and have chosen to continue those. They may have Arkansas Works insurance, or they may be in long-term care, and all of those things are disallowed under the PASS, given specific circumstances. If you don't understand any of that or need additional information, you can always call provider support at DHS for assistance at 888-889-6451. Just a couple of reminders. The updated Outpatient Behavioral Health Services Manual became effective on March 1st of 2019. The Adult Behavioral Health Services for Community Independence Manual, which covers adults age 18 through 99 or 100, with a Tier 2 or Tier 3 eligibility determination who are not eligible for the PASS. Those are Medicaid, medically frail, or spin down. That manual became effective on March 1st as well. For authorizations or extensions of benefits and independent assessment referrals for those outside of the PASS, they will go through EQ Health. And providers should be able to submit EOBs and requests for confirmation numbers to EQ Health for services provided prior to March 1st, 2019. If you have a question about that or having problems submitting to EQ Health, then we ask that you contact EQ Health for assistance with that. Again, a reminder about checking eligibility. Providers are strongly encouraged to check eligibility for beneficiaries prior to the provision of all services. Throughout 2019 and going forward, beneficiaries will be completing periodic reassessments and tier determinations may change. Beneficiaries may change passes during open enrollment periods, resulting in a change of the PASS assignment. So just because they were in, I'm not going to use any of their names, ABC PASS today does not mean that they may not be in D PASS tomorrow. So please remember that beneficiaries during open enrollment periods or the first 90 days of being auto-assigned to a PASS and receiving that notification may change passes, and you will need to then contact the new assigned PASS to discuss or to request services. Also, please remember that Medicaid eligibility may change. Beneficiaries sometimes lose Medicaid eligibility and they will be falling out of the PASS. Beneficiaries also may change eligibility categories. One example of that is if a beneficiary is under medically frail, 06 medically frail Medicaid, and they receive their disability, they oftentimes will move over to traditional Medicaid. When they move to traditional Medicaid, they will be auto-assigned to a PASS, and within 7 days, the PASS will assume responsibility. So just because you have someone who is an 06 medically frail does not mean that they will stay there. If they actually receive their Social Security benefits, they may possibly move over to traditional Medicaid and be assigned to a PASS. And so you may have a change like that. The other thing is that we have had multiple beneficiaries. One of the big emails that I have gotten over the past week and phone calls is about people who are in Arkansas Works who sign up and they are not medically frail. They will have Medicaid during that initial period. It will be under an alternative benefits plan or HCIP. I have that in another slide. I'm trying to think if that's right or not, but it's probably not because it's been a long 25 days. So, Cheryl?
They'll just be under an alternative benefit plan, so an ABP, and then once they move to the R-Works, they'll be in an HCIP.
Thank you. And so when you're looking at that, if they're under an ABP and then move, as Cheryl said, then they will have insurance, and they will no longer be eligible for Medicaid, and they will certainly not be eligible for a PASS or any services. So just be sure that you're checking eligibility to make sure that the categories are appropriate. Just want to also talk, there's been several questions around PCP referrals for those members who've been assigned to a PASS. For those members who are assigned to a PASS, the PASS will process the PCP assignment. So please don't contact Connect Care for PCP assignments for members who are inside a PASS. You will need to contact your PASS to determine assignment of PCPs. And so just want to remind everybody, Connect Care has been getting a lot of calls, and I think there's some confusion around that. So you would contact Connect Care for beneficiaries who are outside of a PASS requiring a PCP, but for those who are in a PASS, that is now going to be managed by each individual PASS. If you need any assistance, you can contact DHS, or each PASS has staff on hand ready to help you. So we've kind of put up the phone numbers. And I'm going to go to the next slide just real quickly to talk about beneficiary support and the contact information for that. So beneficiaries can also, there's lots of information out there. We've tried to post it on social media and everywhere about where beneficiaries can call. If they have questions or concerns, they can certainly call beneficiary support, the PASS Ombudsman Office, or any of the PASSes if they have any questions or need any additional information. And I'm going to go back to, you can also, for providers, contact the DHS provider line, Arkansas Total Care, Empower, Summit, beneficiary support, PASS Ombudsman. We left that out there just so you guys can see those numbers on the screen. And please remember that Arkansas Total Care is listed under Medicaid eligibility as ATC INC Incorporated, and that Summit Community Care is APC Pass LLC. Jason, is that right? Okay, good. So let's go back up and just kind of look through the questions real quickly, and then we'll introduce have the people that are here from the PASS introduce themselves and maybe give you guys a quick update about where they are in the transition process. So I've witnessed beneficiaries that are Tier 2 or Tier 3 that were in a PASS being removed from the PASS. There are multiple reasons why a beneficiary might no longer be PASS eligible. Like we talked about earlier, if they had nursing, long-term care, nursing home Medicaid, if they are medically frail, if they made a choice around AR choices or independent choices. So there's some different ways that beneficiaries might no longer be assigned to a PASS. I certainly cannot tell you why specifically. We'd have to look at each individual beneficiary in order to do that. But there are multiple reasons why they may no longer have a PASS assignment. Will reassessment results be communicated directly? We are working on getting files out for reassessments and making that so that those will come directly to the referring providers for reassessments. We've been trying to really kind of get a lot of other things going, but we are working on a process, and we have a list of looking at those beneficiaries who are outside of a PASS and working on the process whereby we will notify you that an independent assessment needs to be completed, and then we are working on a process for letting you know when that has been completed. PASSes are telling us they have to be reassessed to Tier 3 if they're a Tier 2. That's just not true. So we can talk about that. But when they go into a PASS, they'll go into a PASS whether they're Tier 2 or Tier 3. No, Optum does not do, the question is, does Optum send reassessment results to the providers? No. Reassessment results are sent only to the PASSes. I don't know what the question was, though. So on annual, there is no, so our DHS clients defaulted to rehabilitative? No. There are no priority populations. All beneficiaries have to have an independent assessment to go into the PASS. Okay. If it doesn't show a tier on the Medicaid website, does that mean they haven't had their assessment? Not particularly. You need to go down and look under the Managed Care tab, because they may have been independently assessed and they are now assigned to a PASS. When they become assigned to a PASS, the tier will disappear off the Medicaid eligibility strip. If you still have beneficiaries that have Forever Care listed, then you will need to contact us and we can look at those. So if you have specific cases, what we have found, well, just send those, just contact the provider support line and we'll be happy to assist you with that. So how quickly would the PASS assignment be posted on the website once the IA is completed? So we can go back to that slide, but the independent assessment is completed. The results of that independent assessment are, there's a file that is sent from Optum to another vendor. That vendor then auto-assigns that PASS. The PASSes are notified of that assignment, and they will be responsible for those members, and get away from the word beneficiary, they're members when they go into a PASS, for those members 7 days after that. So beneficiaries will continue to be eligible for and receive services under the Outpatient Behavioral Health Services Program up until the day that they become PASS eligible, or the PASS takes over services. So they will have access to counseling services and mental health professional services under OBHS services manual. Our adult behavioral health services clients who are assessed at Tier 2 or Tier 3, so those are your spin down and your medically frail clients who are not going to get assigned to a PASS, are they required to have a PCP referral? No. If you will go to the manual, which is posted on the website, that is in there. They do not require a PCP referral. There's a question about Tier 2 DD clients. So beneficiaries currently, if they are under a DD tier, then they do not need a BH assessment. So if they have a DD Tier 2, they are going to be assigned to a PASS, and they do not need a BH assessment. And then we might have some additional questions answered. I think you need to reach out to your PASS in terms of compliance issues. No, so do behavioral health agencies have to have a separate certification for adult behavioral health for community independence program? No, you do not. Outpatient behavioral health agencies can provide these services. When Medicaid becomes reactivated, will a PASS automatically be reactivated? Yes. If they are eligible, they will automatically be reactivated. We've already answered that. I think we've already answered that. So we're starting to have a lot of PASS questions. So what we're going to go ahead and do is have our PASS representatives introduce themselves and just kind of give you a little bit of an update. And we have PASS meetings twice a day. And one of the things that has bothered me is that Arkansas Total Care always has to go first. So I'm going to pick on Jason at Summit and make him go first. So
it's alphabetical, I guess. Well, hey everybody, I'm Jason Miller. I'm the plan president for Summit Community Care. Know many of you, probably already fielded some questions from many of you. Certainly glad to answer some of the questions we'll do collectively. Going live on a Friday was a little challenging, I guess, because we didn't have a lot of time to really get to all the questions and answers. Although we worked the command center at DHS over the weekend and answered questions over the weekend, many of them continue to pour in. So we're doing our best to sift through all of that. Our primary focus, and I'm sure the other pastors will say the same, more than anything else, is we want to make sure everybody gets access to care. So obviously we're going to be doing a lot of things and managing a lot of things and working through a lot of issues, but we wanted to make sure as we got started. That's why Friday was a little, I think, challenging, because as you had a major changeover, if there were any glitches or questions or concerns, it's a little hard to remedy those in one day before things hit on Saturday. So we've continued to work through every issue one by one, mostly through our command center here or our folks at our offices that work in pharmacy and other areas. So we'll continue to talk about that. I think for us it's been initially member IDs, making sure everyone had access to the member ID and making sure everybody could get that, which is easily obtained on the website or by calling member services, or your care coordinators who have spent hours over the last week looking up provider member IDs. And then I think from there it's really been the question about PCPs, which I'm sure we'll answer some questions about that. We can get that in a minute, but we want to make sure everybody's got clear information from us. So all of our numbers are open. We're working those all day and on weekends to make sure we get all the things resolved for you. So we'll kind of let everybody else introduce themselves, and we'll kind of get to questions after that. So.
Hey everybody, this is Melissa Ortega. I'm the VP of Clinical Services with Empower. A lot of echoing of what Jason just said. I think here we are on day 5. I think a lot of things have gone a lot better than anticipated. I think we continue to field a lot of phone calls from providers as well as members in regards to access to services, needed prior authorizations, onboarding to portals for authorization, as well as claims payment. We're happy to help resolve those issues and continue to provide support day and night, it seems. So please let us know, reach out, we're available and happy to help solve those issues as they come up, and happy to help answer questions today.
Hi, this is Brian Meldrum. I'm with Arkansas Total Care. We have had what I would call a good start. I think things have actually gone rather well, and may not feel that way from the other side of the fence. So we can certainly understand that people are, facing a pretty substantial change in the process. Continue to reach out to us, continue to let us answer the questions specifically for each pass as to how we're going to handle things. There probably will be some differences between the passes that you'll want to take notes and have your sticky notes and have things handy so you remember how each one might work differently. I think there are some similarities as well. One of the biggest things that has already been pointed out here on the slides is checking eligibility is just going to be critical. Early in the process, I think Jason's exactly right. We're looking to try and make sure that access to care is not interrupted by a new process. So see people, treat people, send your claims in, we'll pay them. We'll work out the ins and outs of the process as we go. We'll try and educate as we go. We know it's new and we understand it's a change. So work with us, we'll definitely work with you.
I think at this point what we may do is look to see if we have some real general questions. I think if you have really specific beneficiary questions or specific process questions for the passes, you're really going to need to reach out to each of those passes. But let's see if we have any kind of general questions in here that they might be able to answer for you. I'm going to kind of skip over questions about benefits plans and medically frail for right now. So I think that a good general question is if a pass changes, which we talked about earlier, there will be a process for beneficiaries moving from one pass to another. So if a pass changes, will the beneficiary need a new authorization for services? So you guys want to?
No, we will work out a transition between the passes in regards to how that information is communicated, but you will not need to request a new the new pass will, I'm speaking for everyone, will honor the existing authorization.
Yeah, just due to the change in status from one pass to another, we're not looking to interrupt care.
Right.
Again, that's the key effort on our part, is to make sure that collectively as passes, we're working together to make sure people get their services.
Agreed. Excellent.
So I think another really good question is, when a prior authorization is requested from a PAS, is the time frame automatically 6 months? And I'm going to tell you, this came from outpatient behavioral health and RSTMI, because for those services, the authorizations were automatically 6-month authorizations. So maybe y'all would want to address that, how the authorization process might work generally.
So currently, I think each PAS has a time frame in which they're honoring authorizations. I know for Empower, we're honoring for 90 days. Others are doing for 60. We will be then reviewing once the person-centered service plan is completed and determining timeframes necessary for services. I think timeframes could be different for different services. I don't know that all services will require an authorization for 6 months, but as we're completing your person-centered service plan, we will be discussing what those needs are so that that can be communicated when you submit for medical necessity.
Yeah, this is Jason at Summit. I agree. I mean, we are also honoring for 90 days any prior authorization that's been done. So again, we want to make sure folks get the care they need to start. We know this is a big change. We don't want to disrupt care, as Brian said, and Melissa as well. We don't want to have people not be able to get their care. Authorizations, at least in our bubble, are not so much about time frame, but more about medical necessity. So there will be times where things are sort of set up on a time frame and feel that way, but typically in a managed system, the idea is that you look at each individual and what they need and make the determination at that moment about what they need, not necessarily cookie cutter everything into a time frame. So it may be that someone gets 3 months or 6 months or 90 days or that is 3 months, right? Or days and months.
It's been a long 2 days.
It has been a long 2 days. So we certainly will do that, but you know, we're probably not going to write everything in black and white and say everything is 6 months or this, that, or the other, because we want to look at, now we understand we don't want you to have to opt something every day, so we're not trying to make your administrative burden tough, but some folks may need services and just don't need it as long as the person next door. And so that person may get a longer off, and that may happen from inpatient to residential to outpatient and all the way down the line, so that we really look at the person's condition, what you're presenting to us, what the person-centered service plan looks like, and combining all that information into the blender and saying, this is what we think this person can benefit from. If they need more or we're off the mark, we can always reauthorize, but probably be a little bit more on the, let's authorize a smaller dose of what we need, see where we are, assess the person, and go forward, versus just saying everything's in a big chunk. I don't know if everybody's doing it that way, but that medical necessity, instead of just getting caught up, and we've had this question, as I'm harping on a little bit, everybody says, well, is everything in the same box? If we leave everything in the same box, we don't change. So we are looking at, to start, we're not changing much. We're certainly honoring all the prior auths and moving forward, but going forward, we will be looking at each individual and their medical necessity and saying, this is what they need, and everybody could be different, even in the same program, if that makes sense.
It does make sense. So this is Brian at Total Care. That's a really good explanation of what we're actually called to do as passes, which is manage to the person and the person's individual needs. So we're going to be assessing as we go. The plan of care is important. So what information you share with us when we ask you to give the input on the plan of care is really important, so that we can tell what's going on with that individual and we can bake that into the plan. So the plan of care is really going to drive a lot of the decision making. There'll be other things like Jason describes, where you'll ask us for services to be authorized, and we'll authorize them for a reasonable period based on medical necessity. So that's exactly the approach that we would be taking.
Thank you. Let's see if we can find another past question.
There were some PCP questions we probably need to talk about. We need to get it out there. Let's talk about it.
We're trying to
PCSPs,
I think an update on where you guys are with the PCSPs, the person-centered service plans.
we're doing them. We're starting to do them. This is Jason again at Summit. The person-centered service plan, I know for us, we had all 280 care coordinators here on Tuesday, and did some conversations with those folks and tried to kind of get everybody reshifted and refocused. We've been training on this for a while and starting to implement it, but honestly, we're not extremely far in the process of hitting all 15,000 members with PCSP. But we are working on that, and that is the driver of a lot of our care. So we are working with you, and we'll be certainly doing this in the DD world, but also in the BH world, to communicate with you, to sit down with you, and that really is a conversation with providers and the member and their families and their supports collectively to decide what we know about the member, what they're getting, and what they might need going forward. And so we're working hard to make sure the PCSPs are done. It will take a little bit of time to get all those done the way we want them, just because we have such a high volume. All of us have a lot of members to see, but I know we're working hard, and the care coordinators will be reaching out and coordinating that with you all every day throughout, infinity, I guess.
That sounds, Jason, that's a great job, Jason. We're going to answer a couple of questions that I'm not going to ask the passes to answer because I think that there's still a little bit of confusion. So I want to make sure that everyone understands what happened on March 1st. Anyone who is assigned a PASS will only receive their services through the PASS. They will no longer be eligible for any service under fee-for-service Medicaid, with the exception of some school-based mental health providers. Those are schools who bill Medicaid for services. So that's not school like I go to a school and provide services. These are schools who are billing Medicaid. Medicaid will continue to pay those services. Medicaid will continue to pay under net transport for transportation services. And there's also, we will continue with managed dental care. Other than that, if that beneficiary is in a PASS, the PASS pays for everything. There is no other access to services except through the PASS, not through OBHS, not through any other service, any other Medicaid program. So just want to make sure that that's clear. Also, I want to answer the next question. What we have had for years is a very siloed system. You were either in DD or you were in BH, and the two didn't come together. So one of the really amazing things about the PASS system is that how a beneficiary got into the PASS is less important than what is on the person-centered service plan. So how a beneficiary gets into a PASS, whether that is through a BH assessment or through a DD assessment, really doesn't matter as much as that beneficiary working with their care coordinator and with whomever else they wish to have participate in the development of that person-centered service plan, and then services are directed across all of those services according to that person-centered service plan. We did away with the silos. So beneficiaries should get the services that are medically necessary and needed based on their individual unique needs and their person-centered service plan. And the passes are nodding. So just want to make sure y'all understand we have to get away from this BH services and DD services. They are now in a PASS, and services are directed by their person-centered service plan.
Could I just interject that because this is all together now, that's why the building out of the network, the completing of the network for each PASS is so important to be able to serve these people and for providers to be able to serve people they've served in the past. So if you're serving someone who now has come over and has eligibility under one of the PASSes, you need to be in that PASS's network, sometime in the near future. We really want to complete our networks. We really want to be sure that services are available, broadly available, and that you can see people in the PASS as a card provider.
So we've got some PASS-specific questions, and we're just not going to answer those. If you have questions that are specific to a PASS, then you'll need to contact that specific PASS for the answers to those questions.
Can I say that, Kenley, your question, you called me about yesterday, Trish?
Yes.
So Kenley, we're working on your answer. I'm glad you put that because I didn't know who told you that. So, we'll get you the right answer on that because whatever you were told was probably incorrect, so I'm getting you the answer. You'll have something today.
I think that we've already answered this question about, you go through each pass for each beneficiary, so I think we already answered that question. Keep going. So I think one of the questions that they have, is about PCP referrals for services, so can y'all address that possibly?
A PCP referral is not required for Empower. Requiring.
PCP referral is not required for Arkansas Total Care.
The same is true at Summit. I want to make sure we're clarifying. I think the question may be, well, I don't know if it's related to the RSPMI requirement or the OBH requirement. So if that's what you're referring to in that question, no, we're not going to require the PCP referral to continue services under the behavioral health services. So that will be done. If you're speaking of a PCP referral to go see a specialist, that's also not something we require. I think all of us are on the same page there. And there may be one or two, something that's complicated. There may be that we seek out other resources if it's something controversial or something complicated, but we generally don't do that. Which is why I think the PCP thing has come up in a few questions about why your PCP and who your assignment is. We want your PCP to be accurate. We want you to have a PCP. And I know in our past we auto-assign folks because that's what our system does. But you can change that in 30 seconds on the web or about making a phone call. But you can also see anybody you want. We've got a 90-day out-of-network waiver. And because you don't need the PCP to refer you to a specialist, if it's incorrect in the system right now or you want to change it, it will not hinder you from doing that at all. So I hope that helps clear some of that up.
Yeah, I just wanted to add, this is Brian at Total Care. We do run into situations where some specialists have their own process for receiving and setting appointments. So don't get confused about the specialist saying, I need a referral, because that may be their own process, that basically they don't just want people calling up on the phone and saying, I want to see a cardiologist. So we want to just clarify that a specialist might have their requirement for getting an appointment on the books, saying, I need this to come from another physician. But that is not a requirement of our pass.
No, I agree with that. I mean, when I see my primary care physician, they oftentimes call the specialist to make the appointment for me, not because it's required, but because they have that that rapport, and that's what those specialists like. So, but we are not. I know at Summit, I don't think any of the passes are requiring you to have a PCP referral by mandate to go see a specialist, but we do. Yeah, we obviously want to work with the doctors to get you what you need. So.
Do you guys want to discuss briefly the process for continued stay reviews for persons who are in RTC right now, or for admissions to acute facilities? I don't know if y'all want to talk briefly about that. I know there's some, is that just going through your websites and just submitting those requests?
Yeah.
Yeah, I mean, this is Jason at Summit, so I saw some questions up there about RTC. You know, again, we're not trying to limit and say if somebody doesn't get a 30-day, immediate 30-day authorization, it doesn't mean they won't still get that. It may mean that we're looking at that individual. For example, we had an individual that the other day has been in an RTC for 9 months, and my medical director wanted some time to review that. We gave a smaller, I think 14 days or something to have the time to review, to talk about where we are, to get a good idea of the case, and then we'll continue to authorize from there. So just call the authorization, call the utilization management department. When you call the provider services line, you can push the button to get UM, and they will look at that case and look at it for medical necessity on a case-by-case basis. But again, not necessarily saying everybody's going to get 30 days, 60 days, 90 days. It will be based on the medical necessity of that member, where they've been, where they are, what they're doing, what we've got, and your documentation will drive a great deal of that. So please, I've said this many, many times, how you document and what you present to us that's the picture of the patient. So give us that picture, tell us who they are, tell us what's going on with them, so we can make a good decision for what they need next. I think y'all would agree, probably.
Definitely second that.
Okay. So let's see if we can find another question for the passive.
Yeah.
Yeah, we're doing some sevens too.
Can I put, I don't actually have the pass reps to put on the screen. I have the information that's on there. But you can certainly go to their websites, and I would manage that, I would assume that contact information is on each of the websites.
Absolutely.
So, do you want to talk about
Yeah.
the treatment? Yeah, okay, go ahead.
Oh, I'm sorry, I was gonna answer the portal question there. from
Oh, okay,
Coach here.
okay.
So, here's what's happening with the portal. We had a Niagara Falls of providers being contracted within the last week before 3/1. You know, clearly, people wanted as much time as they could to make a decision about contracting, and so when they finally did, we had a whole bunch of providers to turn on all at once, and that information is really working its way through the system. So in order to get into the portal, you have to be a PAR provider loaded in the system. So we're waiting on the system load to kind of open the window so the portal is available to everybody. But once you're loaded as PAR, you'll have access to the portal to then be able to request on the portal your medical management authorization request and see eligibility and do all the other great things the portal can do for you. So that's coming. Sorry for the delay, but we just had a bunch of stuff we had to push into the system, and that's what's delayed it.
You want to talk about treatment plans?
Yeah, if y'all want to go ahead and talk about treatment plans?
There's a question up here about how often treatment plans are expected to be completed. For Empower, I know we've talked about this several times in the last couple of days, we anticipate that you would complete a treatment plan in conjunction with the PCFP being completed so that you are documenting on your own provider-specific treatment plan the services that you're providing, the duration and frequency, and monitoring the progress or lack thereof to the goals and objectives that you are treating. We expect for those to be completed on our end annually unless there is a change in condition that requires an update, which would then also be done with a change to the PCFP as indicated. I think all passes, we all agree that that's what we were expecting was the annual treatment plan.
Yeah, this is Jason. So we don't really have I don't think we've enlisted, I think annually is, at least annually would be a good gauge. I would also, the shift a little bit is where the treatment plan sort of used to govern everything in the old RSPMI system. I think now it's the person-centered service plan. The treatment plan is something you use in your house to maintain your service levels and, as Melissa mentioned, goals and objectives. I would imagine all of you who are accredited by Joint Commission or CARC or whatever probably have rules around that, so please follow those rules because we're not going to manage or govern to your accreditation rules, but you're going to want to do that. But build your treatment plan around the person-centered service plan, which is set up, and then again, as they change and update, you do that. But we're not going to require you to fax in your treatment plans to us and show them to us periodically as a source of payment. We need that person-centered service plan. We'll be authorizing days based on medical necessity, and you'll keep your treatment plan for what you do internally. That's how we'll do it, I think.
All right, so just go ahead and let's scroll on down and see. Can you please? Oh, I'm sorry.
I was just going to say, again, I think that there's some specific questions in regards to specific task processes. We're happy to answer those. I think if you call any of these 1-800 numbers that are listed up on the screen, you'll be able to get to us. So just saying that.
So we have can y'all just, all passes, can you please give providers a list of services that require prior authorization? So is there?
For Empower, if you go to our website, getempoweredhealth.com, you go to the Providers tab, there's a reference guide for services that require prior authorization. I know that because I printed it when I came over here, so that's it.
So for Total Care, we actually have a tool on our website where you can enter the code for the service, and it'll tell you whether or not an auth is required.
Yeah, we have the same thing at Summit. It's called Pluto, after the dog. Provider lookup tool, something stands for something. So when you go into the portal, you put in the code, it'll tell you whether PA is off. It'll also tell you if that is a covered service or covered code, so.
I've heard this question a couple of times. Are the passes going to be authorizing any types of packages, or is everything going to be authorized individually?
I know for Empower, for outpatient behavioral health, we did load the current benefit package, but you basically have, it was prorated, is what I'll say. And so if you have specific questions about that, let me know.
Okay, I guess I was reading the question as a group of services could be authorized all at the same time. Is that correct? Is that what this question is about?
That's kind of what I heard it to say is, can you like request like a benefits package for a client versus individual service?
So I think for Total Care, that's a fantastic conversation to have at the time that we do the patient-centered plan. So if you're a provider that has a broad range of services and you think that there's a package that would serve this individual, and it's a set of services that you can deliver, that you as a provider can kind of deliver all inside your family group, your services, that'd be a perfect time to put that on the table and say, here are all the services I want to deliver to this individual. And again, the patient-centered plan, once approved, we're actually building the auths from the plan. So those services would be authorized appropriately, and then, of course, you'd have to reauthorize them on their normal cycle, whatever's required.
Yeah, I think, just Jason, use the person-centered service plan, do that. If they are referring to I know there are the packages that kind of came in the OBH bundle. For us, those are most of those are non-PA services anyways. We don't require prior authorization for therapy and those kinds of things. So there's really not going to be a lot of limits on those. If they need therapy, we'll do that. But for those that need authorization, I agree with Brian. If there is, most of those aren't bundled, I think, that need auth. Mm-hmm. So if you want to do something, I think you can present multiple things. We may still have to auth some of them a la carte, but we can still put it in a sort of a treatment package, if you will, if that works for you and your center. Versus just, I don't know that we've got too many bundled services or benefit packages that are raring to go.
You guys catch this question? We had this question at the town hall. This is about delivering Tier 1 services. So if you're a provider that delivers Tier 1 services and the client that you're serving is somebody that is now in a pass, those are available to that individual. So 1 through 3 services are available in the behavioral health space. So you can go below Tier 2 in terms of services, and the individual is qualified to be in the pass because they got an assessment that said they were Tier 2 for some reason.
I think too, I've gotten this question a couple times this week. If you're a Tier 1 provider, you can provide those Tier 1 services and bill those to the pass if the member has been tiered at a 2 or a 3 and is in the pass.
Correct. Yeah.
Right. You just wouldn't bill Medicaid for those. You would bill the pass because they're pass.
Because they're a pass.
As Trish mentioned earlier, you can't pick and choose for Medicaid or pass. When you're managed by the pass, you're managed by the pass. We can offer Tier 1 services and make sure they need them, we can give them, but you're not going to get fee for service for those. You're going to get, the pass is going to manage those dollars.
So we have another Medicaid eligibility question, and I just kind of want to answer this one really quickly. So when a beneficiary is independently assessed, during that 7 days between when their independent assessment occurs and when services become, I'm trying to think of the terminology I need to use. You guys may want to help me with that. But the pass actually becomes active and they're paying claims.
That's when their eligibility changes.
When their eligibility changes. So their tier will appear. But once they are assigned to a pass, the tier disappears and their pass assignment becomes on the eligibility strip. So if you see a tier 2, then what you're going to have to do is you're going to have to look at their Medicaid eligibility category. If they are O6 medically frail, or if they are a spin-down client, they will never have a pass assignment because they are going to remain in that category. If they're traditional Medicaid, or the Medicaid categories which are going to move over into the pass, then that tier will disappear, and that pass assignment, and that is why we said in this slide, I'm going to go back to this slide, check eligibility every time you see these beneficiaries, because things will change in eligibility based on changing passes, based on tiers, based on pass eligibility. They will change. Be sure you're checking every time you see a beneficiary.
Can you go back up?
Yeah.
I don't know if Diane, there's a question there from Diane. Okay. So I don't know if this is what this question's about. There's a question that says, what's the prognosis for getting the problems with overextending on authorizations resolved? But is that related to this? So I don't know if this is it or not, but I know in our past, and I hope y'all can confirm or not in your past, we are not limiting the number of prescriptions to only 6 per month. So folks can get more meds filled than 6 per month. Now we're obviously looking at ways we can find cost savings in pharmacy and manage better and come up with plans on how we can do that with our providers. But if they need more than 6 meds a month and it's justified, we can authorize that. The same is true for the PCP visits. In Medicaid, they were limited to 12 visits per year. That is no longer a limitation in our pass. I think they were the same.
Yep.
So all passes allow more than 12 visits per year. So while there are things we're going to manage and look at, there's a lot of things we're making better, I think, and allowing people to have more visits to their primary. Now, if they go 42 times to the PCP, we might be looking at what the heck's going on. But obviously 12 may not be enough, and if they need to go to the PCP, we will allow them to go to get more than 6 meds per month as well. So some good things happening. Also change some benefit limits, things that are giving opportunities for members to get a little bit more services. I don't know if that was the actual question, but I wanted to make sure we talked about the 6 med limit because I think that's come up several times.
I think there may be one more. I agree. All 3 passes are lifting the visit limit for doctors, the limit for scripts per month. But I think there's also a cap on spend for radiology and lab.
Yeah, we've lifted
$500. I think
that's true.
So I think we've lifted that as well.
Yeah, we've lifted that as well.
So the theory here, just to share, we're not out of our mind. We're not just spending to spend, but our theory here is that it didn't make sense to ration the things each month or to ration the visits to the doctor, when in fact a visit to the doctor could save a visit to the hospital. Or the right set of medicines could treat someone where medication costs weren't out of whack and weren't crazy, and people weren't having problems,
Right.
And cycling into crisis. So
And I mean, the lab limit was $500. You could use that in one session with an X-ray guy, with an X-ray in a lab. So
Right.
so we did lift some of those things. So that gives, again, opportunities for us to do some things with members that are good. And then, of course, lifting the specialty requirement to get a specialty referral. So I think all of us have done some things to make it better for the patient to get services that they need.
Just want to talk a little bit about clients. So we had a period of time when we were transitioning from Beacon over to the PASS and to EQ Health. EQ Health actually had already been doing things, but for those Tier 2 and Tier 3 services. So we do have some beneficiaries that do not yet have authorizations. And so we're just, I think what Brian said earlier is that we don't want people to go without services. So we're working with the passes to ensure that there's no gaps in services as they move from one program to the other program. So please be patient with us. It's a big project, but there is a process going on. So just go ahead and request those EOBs or those confirmation numbers. like you're doing right now through EQ Health to cover those services, and we are working on a process for that to ensure that beneficiaries and services are covered. I think we've already answered those questions. Keep on. We're kind of getting close to running out of a little bit of time, so we're going to kind of go ahead and look to see if there's some really...
Oh, there's one that's a good point.
Which one?
The one below that. Are 90 days honored for inpatient behavioral health services as well? That's a no for Empower. I think that's a no for everybody.
No for us, correct.
Inpatient services do require authorization. Acute is an acute service. Residential is still a higher level of care, so those are not being honored for a 90-day transition time frame.
I think that next question, maybe Melissa, y'all might want to talk about that. I know that providers are going to be submitting claims this week, so do you and Brian and Jason want to talk about what needs to be submitted on claims or batch files or anything, or they just need to reach out?
First of all, we've already had a couple hundred claims submitted,
Okay.
so it's not just this week. I think 80 went out to be paid today, so that was good. I know for us, we're paying on a daily cycle for a while because we're also trying to audit, I'm sure y'all may be doing the same, but trying to audit the claims and to make sure they're right and that we've got you paid right and everything's there. So when you do that, it takes a couple extra days. So we've moved our pay cycle from once a week to daily, 6 days out of 7, so we can get you paid. You know, we want every bit of information you can give us. I think in our system, if you're the provider, as long as you have your provider Medicaid ID or your NPI, it will go through, I think. I don't think you have to have both, although having both is ideal. But I think you can use either in our portal to get yourself in. And when you're in Availity, our system, as you go through and build a claim, there are asterisks next to the boxes that are required to do. So I don't know if y'all's is the same, but.
Yeah, for Total Care, MPI, Medicaid ID, or member ID from Arkansas Total Care would be needed on the claim, so we can match things and make it pay. We've seen a bunch of claims move into the system, adjudicate, process out to be paid. We'll be making our first payment on Monday.
Same for Empower. Same process. We are actually making our first run tomorrow on Friday.
There was a question on there that I thought that would be a good question for everybody, and that was about rate changes with therapeutic communities. So do you guys want to talk a little bit about rate changes? Yes, no?
Not really.
Okay.
I don't know. I don't have all that.
I don't know
I'm
what
sure
the
either.
rate changes.
Yeah, I don't know what that is either.
So,
you guys said Medicaid changed the rate?
No, we have not changed the rate.
Okay, so what's
the
the
question was, and we can't find it now. Oh, there it is. Will the per diem rate for therapeutic communities vary by individual? So I think that the rates are.
Usually a rate is a rate is a rate.
Yeah.
And if you know, sometimes where you differ between individuals in their need of the services, but the agreement with the provider says we're going to pay you this rate, we're going to pay you that rate, and then we'll just authorize to the number of days or time they need it. We don't build contracts based on what a member needs. You'd never stop building contracts. So I don't know that now we might negotiate a rate or something in the rate negotiation with the provider if that's necessary, but it wouldn't be member specific. Is that right with y'all?
That's correct.
Yeah.
I don't think we do.
The rate for Medicaid is the rate we're using.
Yep, that's one we're using too.
Okay, we're going to go ahead and wrap up. I do want to ask, though, of each of you, if there's anything else that you want to, any closing?
I think someone asked if Total Care was honoring auths for 90 days. No, we're honoring auths for 60 days. But at the same time, if you've got something that's an item that you would like us to address, just reach out to us and let's talk about, what the situation is. So we're flexible.
Anything else?
I would just like to say I appreciate everybody for reaching out. Please continue to be patient with us. I assure you, I give you my word, everything we are doing is trying to make this work and make it better. There are no mandates or sneaky solutions. We're just trying to do what we need to do to get this to work in our systems. we're giving, I think all of us are giving a lot on the front end to make sure people get access, to make sure we're doing what we can. We're not trying to hold your feet to the fire or be too restrictive at the start so we can get this thing done. But just be patient with us and call us and ask us questions, and don't assume we're doing something wrong or read it on Facebook or something and think it's the world's coming to an end. We really are all trying hard to make this work, and if you'll give us just a little time or ask us questions, I think we're all trying real hard to get your questions answered and make it as easy as we can. We're going to have glitches, we're going to have barriers. We went from one system to an entirely different system, but I think everybody's working day and night to make those work. So please work with us and be patient, and I know everybody's really good people trying to do some good things. So I would just ask you to give us a little time.
Agreed. We're happy to answer those questions. Just please reach out. We're all on the phone all day and all night and are happy to help do what we can. So just let us know how we can help. We're here.
By the phone.
That's
Yeah,
right.
we are.
So I've got to correct myself already. I got a note from the office. So the authorizations are being honored for 90 days. The 60-day time frame is for whether you're par or non-par.
Yeah, the network thing.
Okay.
Okay.
All right. Well, thank you guys very much.
Thank
This
you.
does conclude our webinar for today. I want to thank Trish and as well as each of the past representatives for their presentations and answering of questions. As a reminder, today's event was recorded and will be posted to the AFMC website. All attendees will receive an email including a link to the recording. Thank you very much and have a great day.